Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight, our guest and my friend and colleague is Dr. Neil Horning. Welcome, Neil.
Hi, Dick. It's so wonderful to be here. Thank you so much for giving me the opportunity.
Thank you for being here. Neil and I were chatting. He grew up in Tennessee and did undergrad in Tennessee and then medical school at Washington University, St. Louis.
Exactly.
Did his internal medicine and pulmonary and critical care fellowship there. So
Right.
Dr. Horning, Neil is the director of the MercyOne Lung Cancer Center. He's also, as I said, a pulmonary care lung doctor and a critical care doctor and a good colleague. And we've been working together for 25 years.
Exactly. Yeah. I've been here in Des Moines at MercyOne for 25 years. It's been a long time. It's been great, though.
So tell us a little bit about yourself. When in your life did you know you were going to be a doctor? Was that something you thought about in grade school? It was high school teachers.
Sure.
It was
Well, I guess my joke is I decided I was going to be a doctor when my dad told me I was going to be a doctor. But, he said, you can be any kind of doctor you want to be. But no, in reality,
was your dad a doctor?
No, he was a pharmacist and worked for a pharmaceutical company, which was originally S.E. Massengill, which became Beecham Massengill, which became SmithKline Beecham, which is about when he retired, which eventually now is sort of grown into GlaxoSmithKline. But he worked at the pharmaceutical company down in Bristol, Tennessee, and was the head of regulatory affairs and submitted FDA applications for medications like amoxicillin, Augmentin, and things like that. So, and my brother was a dentist. And so, it was for a very medically oriented family. So, it was sort of a joke, but I mean, I always really kind of wanted to be a physician and decided to go into pulmonary and critical care after, when I was in my internal medicine residency, we rotate through all these different types of, all the different subspecialties. And, Barnes had, a really strong pulmonary and critical care division. And so it was something that I really, wanted to do. And and I think it's been a great choice. And I've loved this profession.
And boy, like every field of medicine, things change over time. One of the things that I just observed working with you in the hospital is the way critical care has become like a real critical part of the hospital. It seems to me, and I'm interested in your perspective, that back when I came 30 some years ago, the docs that managed the patients in critical care were doing all sorts of other things, and they also were managing critical care patients.
Right.
And now we've become to realize that critically ill patients need a real dedicated specialist tending to them.
Yeah, I think as the last few decades have worn on, the science of critical care has advanced. Our abilities to support really, really sick patients, the technology that we have, the machines that we have to support patients have all advanced a lot. And so what started as, critical care is one of the kind of the newer specialties in internal medicine and surgery and these other things. But, realistically, that the technology, like in a lot of specialties, the technology in critical care has really advanced. The things that we can do now to help support patients while they're so critically ill and help them, get through that critical illness and move on and live the rest of their lives is really remarkable. I mean, sometimes you walk down the hall of one of the critical care units and see, how many different machines somebody is on, an ECMO machine, like a heart-lung machine, and a ventilator, and some other sort of heart support device, and all these different kinds of medications. Now, it's really, it's a big change from even when, 25 years ago when I started.
And one of the things that I just observed, not being a critical care doctor, but seeing patients who are in the critical care, that it used to be 30 years ago, if somebody got put on a vent, I mean, they were like at the very end, and there was just are they going to make it? And now the use of a ventilator for patients to help them recover, it's used much more liberally than waiting to the last minute to ventilate somebody.
What I try and tell patients is that when somebody is sick enough, their breathing is bad enough, they're otherwise ill enough that they need to be on a ventilator, we're trying to buy time to help the rest of their body get better. But although it used to be the mortality for anybody that comes to the critical care unit is like 25%. Those numbers are better now because of the technology, the medications, all the things that we can do to help support patients through that.
So tonight we're going to focus on the pulmonary, the lung aspect of your specialty. So among the things that Dr. Horning does, he also is director of our lung cancer center and our multidisciplinary lung cancer center. So what the heck does that mean? A multidisciplinary lung cancer clinic?
Well, like with a lot of cancers, but especially lung cancer, it takes many different types of specialties, many types of doctors to diagnose and treat someone with lung cancer. It has to be diagnosed in the first place, and oftentimes that may be the primary care physician who gets a chest x-ray or a CT or a lung cancer screening CT scan to find the cancer in the first place. And then someone needs to diagnose that. Most of the time it's a pulmonologist, a lung doctor like myself, to sort out what type of biopsy. In order to diagnose lung cancer now, at least, we need tissue, we need a biopsy. So you need a pulmonologist to do that. But then once we have a diagnosis, it's, the treatments have advanced significantly over the last 20, 25 years. So we have radiation oncologists, radiation, medical oncologists, give medications, surgeries, surgeons, thoracic surgeons, in addition to all the different support staff at the lung cancer clinic, at this multidisciplinary lung cancer clinic. The way that office visit is designed is so that patients are able to see all of those different specialties all at the same time, all in one visit. In the good old days when I first got here, patients would need to come to our office, then they would need to go separately to your office or one of your partner's office to talk about radiation oncology, then go to a separate visit to the medical oncologist, then maybe go to the surgeons, then maybe come back.
Sometimes there were 2 weeks in between each of those visits.
Exactly. And if they're coming from Newton or Bloomfield or wherever, it's a really long trip, and it was really inefficient, and it was stressful. That they already have a lot of stress because they've got lung cancer. We need to get this thing treated immediately. So what we did was kind of reverse that, flip that on its head in a way, and put the patient at the center of what we're doing. So the way the lung cancer clinic works is patients come in and the appointment is set up ahead of time. So we know which of those specialties the patients need to see. So they come in, it's on a Tuesday afternoon, once a week, but they meet with the pulmonologist, the lung doctor, they meet with medical and radiation oncology. And if they're a surgical candidate, they meet with the thoracic surgeon. And because it's one visit, the family can be there with them. It can be much more convenient for them. The way the cancer is set up, it's easy to zoom in for patients. There are big screens, and
it's family members from around the country can also participate.
It's a wonderful location. It's a wonderful space. So that's its own advantage. And because the patients and their families are there at one time, Donna Van Berkom, our lung cancer navigator, can be there with them to help sort of translate what the physicians are telling them. And the idea is that the doctors can get together because we're all there at one time and come up with whatever plan we think may be best for them, or to be able to present those options to the patient. The patient, the family can be there and hear all these different options. And so you can come up with a plan, a treatment plan that's really designed for the patient, what's best for them.
Yeah. And as you said, I think the real key is it's patient-centered, that the patient comes, and it's a little bit less convenient for all the doctors to come over to this one center and see patients, but it is very patient-centered, and that's what the whole focus is on. Right. And so lung cancer is the most significant cancer that we have, probably in terms of the number of people in the United States who die of a particular cancer. Lung cancer is the number one.
Right. More patients. So when you look at the percentage of cancers in different genders, the most common cancer in men is prostate cancer. Second most common is lung cancer. For women, the most common cancer is breast cancer. Second most common cancer is lung cancer. But more men die from lung cancer and more women die from lung cancer than breast or prostate or these other sorts of things. So it's unfortunately it's a cancer that's the number one cancer killer.
Yeah. And so let's talk, we're going to talk about prevention, we're going to talk about screening, and then we're going to talk about diagnosis and then some treatment. So let's start with prevention. What causes lung cancer?
Well, the most common cause is cigarette smoking, above and beyond anything else. It's the number one. It's not the only cause, but it's the number one cause. Cigarette smoking, secondhand smoke exposure. There are other types of environmental exposure as well, like radon, asbestos can, certainly cause mesothelioma. And I think in general, like a lot of things, it's a combination of genetics and environment. There are people who can smoke cigarettes, and if they got the right genes, they don't get lung cancer. But unfortunately, many people who smoke get lung cancer. So realistically, the most important thing we can do to help prevent lung cancer and to prevent heart disease and stroke is to help people stop smoking.
Not start to
Exactly.
begin with.
Well, not start. Yes, exactly.
And that's part of kind of a youth campaign,
Yeah,
not start.
exactly,
And if
exactly.
you do smoke, to stop. You did point out that not everybody who smokes gets lung cancer, clearly, and not everybody who has lung cancer has smoked. So
Exactly.
I think about 25% maybe of people who get lung cancer don't smoke. And it seems that women, non-smokers, kind of make up a large percentage of that 25% of non-smokers who get lung cancer. And as you mentioned, radon is really significant here in Iowa because we have more radon exposure, unnatural. It's not a pollution. It's a naturally occurring radioactive gas that comes up through basements. And there again, prevention can be knowing that radon exists, testing your home, and you can mitigate your home with some fans that help reduce the radon. So, so that would be kind of in the world of prevention. If you don't smoke, don't start. If you do smoke, stop, and then also mitigate for radon in your home.
Right. And, when it comes to smoking cessation and tobacco use cessation, here in Iowa, we have the Quit Line Iowa. And with MercyOne, we are starting or have started again a smoking cessation program through our office, but it's open to the public and to anyone within MercyOne. And it's all anybody needs to do is just call our office or talk to your own physician. It's 515-643-7900. But no, we're really excited to get that smoking cessation program up and running again because it's an incredibly useful program for people that want to stop smoking, but it's incredibly hard to stop. It's one of the hardest addictions to break. So I think any help people can get, I think is important.
Let's talk next about screening. So there are 5 different cancers for which we have validated evidence-based proof that screening helps reduce death rates. Those 5 are breast cancer, which is mammography, colorectal cancer, which is either a colonoscopic examination or a stool test, cervix cancer, which is a pap smear, prostate cancer, which is a blood test, and lung cancer. So we have an evidence-based lung cancer screening tool. Tell us who is eligible for lung cancer screening.
So currently it's patients who are considered high risk for lung cancer, age 50 to 77, a 20-pack year history of smoking. I'll explain what that means in a second, and have had to smoke within the last 15 years. We talk about pack years of smoking. It's just a way of quantifying someone's cigarette use. So if I smoke 1 pack a day for a year, that's 1 pack year. If I smoke a pack a day for 10 years, that's 10 pack years. 2 packs a day for 10 years, that's a 20-pack year history of smoking. So it's basically, again, a 20-pack year history of smoking, had to smoke within the last 15 years and aged 50 to 77. And that those criteria have changed over the last couple of years. All the, this idea of lung cancer screening has been around since around 2011, 2012. For a long time, lung cancer, we were one of the most common cancers that didn't have some kind of validated screening tool. And that led to, the really bad outcomes and high mortality for lung cancer, because unfortunately, people with lung cancer wouldn't develop symptoms until they already had metastases, bone metastases, whatever. They would start to have pain, and then their doctors would work them up. And it's like, oh my God, you've got, metastatic lung cancer. So the outcomes were pretty bad. But finally, in 2011, the National Cancer Institute developed this study and published it in 2011. And they compared just regular chest x-rays versus low-dose chest CT scans in people who were at high risk for lung cancer. And unlike all the previous trials, all the previous failed attempts, this trial actually worked and showed some really good outcomes. They showed a relative reduction in lung cancer mortality of 20%, 20% relative reduction in lung cancer mortality, and almost a 7% reduction in all-cause mortality. And, people ask, well, it's a CT scan of the lungs looking for lung cancer. How are we decreasing all-cause mortality? Well, it turns out, chest CT scans show more than just lung nodules. They're finding emphysema, aortic aneurysms, liver problems, all kinds of other sort of conditions. So, with those really good results, insurance companies started to pay for it. This organization, United States Preventive Service Task Force, they endorsed it, and a lot, American Cancer Society, all these other groups have endorsed it. And just in the last few years, they've broadened the enrollment criteria, so even more people are eligible for lung cancer screening now. And the test itself is pretty easy. You keep your clothes on. We tell people we're explaining that what's involved in this lung cancer screening, and it sounds ominous, but it's really easy. Keep your clothes on. Don't have to have an IV. It's a CT scan. It's not like an MRI. So usually people who have claustrophobia can handle it okay too. Takes, I think, it's one breath hold. It's like 30 seconds, I think. And the amount of radiation is more than a chest X-ray, but lower than a regular chest CT scan. And the way that the system works is, as long as someone is eligible, then it's one CT scan every year. And the idea is it's not just a one-time thing. It's like mammography or any other sort of things. You need to kind of get these scans, at least for the lung cancer screening CT every year, as long as you're eligible.
So again, the highlights it's for people at higher risk for developing lung cancer. So that population is a smoking history. So either a current smoker or that you haven't stopped more than 15 years ago. So you've been smoking within the last 15 years, and that your cumulative amount of smoking over your lifetime equals 20 pack years. And then also that age. So it's you've got to be 50 to be eligible.
Right.
And you screen up through the age of, did that get extended to?
Well, and this is where it gets a little 77 for
77.
sure. 77 for sure. Is Medicare will pay for 77. United States Preventive Service Task Force recommended up to age 80.
Okay. So somewhere between 77 and 80. It's and some of that becomes, if you've been screened every year for that many years, and how many years do you have left to live?
Right. Are
you going to show an improvement in overall survival? So it's based on evidence. As you pointed out, without a screening test, at least 50%, and correct me if it's of people would present with stage 4 lung cancer, treatable but not curable. Right. If you can be found at stage 1, you probably have at least an 85% cure rate. But if you don't find it early, then you've lost the opportunity to cure it. So what lung cancer screening has done is not just find the lung cancers, but find it at a stage when it's potentially curable.
Exactly. Most of the cancers that we're finding in the lung cancer screening program are those early stage cancers. I think more than half. And that's held every year that we look at that data. And so, the majority are stage 1 or 2, which, is potentially curable. And that's the whole point of it, to stage shift, to take that big group of stage 4 and shift it over to when they're diagnosed down to stage 1 or 2.
So, showing my age, I graduated from medical school in 1980. Back then, we sort of went through this. First thing you had to do was submit sputum samples to see if you could find some cancer in the sputum. Yep. Not a very effective way of finding cancer. Yep. And so then you had to wait till that was done. And then it was like, okay, maybe our one lung doctor that can look down into maybe we can get him scheduled for the patient scheduled for that, a bronchoscopy, or we could maybe have a radiologist to stick a needle through the chest and hope that you don't pop the lung and deflate the lung.
Right.
How have things changed, and what would you say the current in the MercyOne lung cancer clinic? What's the thought process of you've done an X-ray, there's an abnormality, it may be cancer, but we need to have a piece of it to know.
Right.
What's the next step in the decision tree for what you do with a patient where you've just found what looks like a tumor in the lung and it doesn't appear that it's anywhere else?
Right. So as we like to say, tissue is the issue, right? So you need to get a biopsy one way or the other. And basically, still, as you described, the main two ways of getting, for now, a biopsy is either coming from the outside in with a CT-guided needle biopsy, where interventional radiologist, has a person back in the CT scanner, maps out exactly where that nodule is, and puts a needle in through the chest wall into that. And now for lesions that are really peripheral, sometimes that's the first choice. For other kinds of lung masses or nodules that are more central or more difficult to get with a CT-guided biopsy, or if there are other things that are going on, I'll talk about in a second, a bronchoscopic procedure is preferable. And there's a lot of new technology that's come along in the last few years that help make that procedure safer.
And just explain what a bronchoscopy is.
I will. Right.
Okay.
So it's a lot safer and higher yield than it used to be. A bronchoscope's basically what a bronchoscope is a scope or a flexible fiber optic instrument that you can go through the mouth or nose, into the windpipe, into the trachea, and look inside the airways. There's a light and a camera on one end, eyepiece on the other. And that technology of this flexible fiber optic instrument has been around, probably at least since the 60s and probably even before that. I think, even rigid bronchoscopes have been around maybe for 100 years or so. But, up until just recently, the bronchoscope, and it's about as big around as a pin. It's not really that big. It's like about an ink pen bigger, and there's a side channel that you could put instruments through. So a traditional, the older kind of bronchoscopes, you can get out pretty far, but only about maybe a third of the way out into the bronchial tubes. You can't get out to the edges of the lungs or the periphery or do anything like that. So, when I was a resident back in the 90s and we wanted to biopsy something, we would kind of guesstimate where that lesion is by the CT scan. Oh, it's in the right upper lobe anterior segment. So we can sort of blindly put the forceps out, and we'd have a fluoroscope looking to see with like a motion picture X-ray to kind of look and see if we're in the right space. And oftentimes we were, oftentimes we weren't. But now there is this navigational robotic assisted bronchoscope, which is, some pretty remarkable technology. I was sort of thinking about where things were like 20, 25 years ago, 10 years ago, to where we are now with ways that we have to diagnose and treat lung cancer. I mean, it's like light years beyond where things were in the past. So with this technology, it's safer, and you can get a higher yield, a better chance of getting a diagnosis. So the way this works is this computer program takes the CAT scan images, and because those images are basically data, or, it's basically, just sort of ones and zeros, it can take the CT scan images and create a 3D map of the bronchial tubes and create a map of where that nodule or maybe multiple nodules are, and then basically creates a GPS directions with this computer program to figure out exactly which bronchial tubes to go through to get to that spot. Then when the patient comes in and has the procedure done, it's called a robotic assisted bronchoscope, because what happens is this is done under anesthesia. So people are asleep. They don't remember any of this. But, go in with the bronchoscope. And then, as I said, the actual bronchoscope itself can only go so far. But with this navigational device, the robot kind of helps guide out where to follow the
So
map.
as you're going down,
Yeah.
you come to a forks in the road.
Yeah, exactly. Exactly.
And it's not unlike Google Maps where you're
Yeah.
saying, take me from here to here.
Yeah.
You come to an intersection and it tells you to turn left or right.
Right. Exactly. Exactly. And the robot helps sort of guide this thing out there. And, you can't exactly visualize it just with your eye in the bronchoscope, but with this device it's very thin and go out to sort of the farthest outreaches, the thinnest parts of the lungs, and we can get biopsies that way.
So you head down, and the first thing you come to the main fork in the road. Are you going to look left lung or right lung? You probably could guess that turn yourself. And so you go that way, and then you come with the next fork in the road. And it does it show you? Does it tell you? Does it speak?
Well, it doesn't talk, but I mean, it's multiple screens,
Uh-huh.
so you can see, inside the airways of the lungs and see this like blue line, just
and
like
that,
Google
so
Maps.
it is a blue line that points to which fork.
And the robot kind of helps guide this little thin catheter out that you could do biopsies.
And the idea is to get out into the lung to as close as possible to where the tumor is.
Exactly.
And then once you're there, you deploy a needle that goes
or even
through.
little forceps, and get little pieces of the tissue or brushings.
And so the advantage is, as you pointed out, you're more likely to be in the right spot. Also, you're biopsying the tumor that way is less likely to cause a pneumothorax, a collapsed lung, than putting a needle in through the outside.
Especially for people who have abnormal lung tissue like emphysema, putting large needles through that abnormal lung tissue, you're a lot more likely to get a pneumothorax. People get pneumothoraxes even with this robotic bronchoscopy because you're taking little pieces of lung tissue, but it's safer than the CT guided needle biopsy, especially with those, nodules that are more towards the center of the lung.
So getting a piece of the primary tumor is important. One of the first places that the lung cancer can spread is to lymph nodes in the center of the chest. So you also have an ability while you're doing the bronchoscopic examination to use an endoscopic ultrasound to kind of visualize the lymph nodes to see, does it look like they are abnormal? And if so, to even biopsy.
Right, exactly. It's called an EBUS, endobronchial ultrasound. And it's a different scope, similar. It's another flexible fiber optic instrument, but this one has an ultrasound on the end. And exactly what you said, we can, if the airways are like pipes or tubes, the lymph nodes where the cancer can potentially metastasize to are sitting on the outside of those tubes of those airways. And so now we can, with the ultrasound, look to see exactly where that lymph node is, see if it looks abnormal, and then put a little needle through the airway wall. It's a very small needle, and get samples of the lymph node that way so we can stage it and we can diagnose the cancer and stage it all in one procedure.
Okay. So now this sample patient, we've done that, and we found that there is cancer in the primary tumor. It's a lung cancer. We'll say it's a non-small cell lung cancer. We'll talk more about that. And the lymph nodes are not involved. What are the other tests that we would do as part of the staging workup now that we've proven that there's cancer in the lung and it doesn't look like the lymph nodes are involved? What are the other?
Another relatively new technology are PET scans. I mean, it dawned on me the other day when I was thinking about this, so when I first started, PET scans were just starting to kind of come into their own for staging lung cancers. Now it's like routine. But so, when we've diagnosed someone with lung cancer or other kinds of cancer, you can get a PET scan. And it looks for, what I try and tell patients is it's a metabolism scan. It's not exactly a cancer scan, but it's just looking for areas of the body that have increased metabolism. And oftentimes, if it's a lung cancer, the lung cancer will show abnormalities on the PET scan. If the lymph nodes are involved, they'll show abnormalities. But what we're really looking for is liver, bone, other places like that. And oftentimes I'll also get an MRI of the brain because the PET scan, there's so much metabolism going on in the brain that the PET scan is not great for looking at the brain.
And the brain is one of those sites that lung cancer likes to go to if it were to metastasize.
Exactly.
So in our patient that we did the PET scan, the MRI, the cancer is only in the lung. Let's talk a little bit about what did the biopsy showed. I said it showed non-small cell lung cancer. Maybe explain what are the different types of lung cancer.
Right, exactly. So there are two main groups of cell types. There's small cell lung cancer, used to call it oat cell, small cell lung cancer, and non-small cell lung cancer. Under the non-small cell lung cancers, there's adenocarcinoma, one of the more common, squamous cell carcinoma, large cell. Then there's this other group of like, maybe more in this other family of small cell-ish, like carcinoid types of tumors that we see kind of more. I don't know, we've seen sort of a string of those lately, but the main groups are small cell, and then for the non-small cell, adeno, squamous, large cell.
Mm-hmm. And the most common lung cancer in this day and age is the adenocarcinoma of the lung, one of the non-small cell lung cancers. And nowadays, we don't just have the pathologist tell us from looking at it under the microscope what it is. We do all sorts of testing, and there's about 30 different tests on this adenocarcinoma cell to see whether it might have any special markers that might have treatment significance.
I mean, that's really another one of these really dramatic changes that I think I was trying to think to myself, if I could go back in time and talk to myself as a medical student, all the things that we've talked about so far and we're going to talk about in a minute would almost be like science fiction. Oh, well, we can take a look, the pathologist can look at this, the cells of the cancer, find out what markers there are and direct, specific therapies for that. So especially with adenocarcinoma and with squamous cell carcinoma, there are a number of these different markers, PD-L1, ALK, EGFR, all these sorts of different markers. And, again, it used to be back in the days, there was only chemotherapy, but now there are these directed systemic therapies, immunotherapies, other kinds of therapies that based on the kinds of markers and what combination of markers and what levels of the amount of markers there are, the medical oncologist can direct therapy specifically for that. That's less toxic, more effective. It's really remarkable.
Right now, the state of affairs is that if it's a stage 1, we generally don't use any of the medicines. So it comes down to, generally speaking, 2 different options. Either surgically remove it or use radiation to kill the cancer cells.
Right.
Talk about surgery and some of the newer things we're doing now. So lung cancer surgery used to mean big incision that went from the front to back all around the side. You take it up and you remove a bunch of the lung and then sew you back up again. And,
exactly.
And that's still sometimes done. And I made it sound a little cruder than it is. But, we are focusing not just on trying to find cancer early and cure it, but also use techniques minimally invasive that have fewer side effects for the patient.
Right, exactly. As you said, it used to be, for a stage 1 lung cancer, well, when we diagnose the lung cancer, one of the questions is, are they a surgical candidate or not? And oftentimes that a surgical candidate means that someone wants to, it's the patient's choice, number 1. But number 2, they need to have good enough lung function to be able to tolerate having part of their lung removed. And that involves having breathing tests, pulmonary function tests to see, again, how good or bad their lung function is, because, the surgeon's going to have to remove part of their lung, and depending upon what part of and what side of where the tumor is, they may have to lose a significant amount of lung tissue. So he's got to make sure the breathing is going to be able to tolerate that, and also that they don't have other sort of comorbidities, significant heart disease, these other sorts of things.
So their heart and lungs have to be strong enough and kidneys strong enough to withstand the surgery. And then they have to have good enough lung function that they can function with part of their lung missing.
Exactly. And most people can. Now, as far as the surgical techniques themselves, again, the advances are really remarkable. Even, in the years that I've been here, it's changed. It used to be, as you said, I mean, the thoracotomy scars when I got here, along the back, kind of from the top to bottom, and they would spread the ribs and take out a big, a whole lobe of the lung, and people would be in the hospital for a week, and they'd be sore for many weeks and numb and have chronic pain and their cancer.
Chronic pain for years. Sometimes.
Exactly. Good news, we cured your cancer. Less great news. You have all this pain and numbness, and things aren't as great as they were. Now, however, just like they can, surgeons can take gallbladders out through, small incisions with little tubes. They can do that now with lung cancers, these minimally invasive surgeries. Again, robotic assisted, with these small incisions, these little tubes, and go in and remove parts of the lung that way. And there's less morbidity, meaning there's fewer, less pain, less time in the hospital, less time with big chest tubes draining, blood and fluid and things like that. And the outcomes are just as good or better as far as curing the cancer.
Mm-hmm. And then the other way, so surgery as an option, is pretty much kind of the gold standard. I mean, surgery removal of lung tumors has been around for a long, long time. Radiation for lung cancer treatment has been around for a long time, but usually it was done only in those patients who couldn't have surgery. So it was considered sort of the alternative, the second best thing to do if a patient just couldn't have surgery. Right. And now we've come to techniques. Maybe talk a little bit about stereotactic radiation therapy.
Well, sure. I mean, I think, you're the expert in that. I'll give my introduction, my perspective. I'll let you talk about that. But I think, again, I guess the theme of everything I say is things are a lot better than they used to be. And, it used to be with radiation therapy, it was 4 to 6 weeks every day, a large field of radiation being given. Patients, felt fatigued and sometimes had a sore throat and had trouble swallowing. And now if the lesion is a reasonable size, with stereotactic radiosurgery, it's like a laser beam versus, a shotgun or carpet bombing. Yeah. It's like, instead of carpet bombing the town, it's like a smart bomb. It's like a laser beam onto this lesion. And patients, is it down to 3 days now?
You can do it in 3 treatments.
Yeah. Right. So it's incredibly effective, and patients, at least my experience from the people coming back, have very few side effects.
Very few side effects. So you're right. The side effects that you will have from radiation depend on 2 things. One, the size of the area you're treating, how much normal anatomy is there, and what dose you're giving. And the old-fashioned way, I mean, we're talking about 40 years ago, patient laid on the table, you treated from the front and the back, and everything in front of the tumor got the same dose as the tumor, and everything behind the tumor got the same dose. So you caused a lot of irritation of the esophagus and the trachea. And then you also caused a lot of lung damage that even though you didn't remove the lung, you may cause so much scarring that it doesn't function as well. So now with what we call stereotactic radiosurgery, there's no surgery involved. We use a very small beam that's maybe only an inch in diameter, and we might come in from 100 different directions. And the idea is all 100 beams converge on the tumor. So the tumor gets 100% of the dose. But if you use 100 beams, any of the normal tissue that any one beam goes through only gets 1% of the dose. So you really concentrate the dose on the tumor. And since you're just treating the tumor, you don't have to treat a lot of extra tissue. And so most patients have just some fatigue as a side effect. The other thing that is amazing, what is one of the challenges of treating a small tumor in the lung? So if you treat a small tumor in the brain, it's relatively easy because that tumor is not moving. But if you have a tumor in the lung, it is moving, sometimes even 4 centimeters if it's in the lower lobe, with every breath. So the particular radiation machine that we use is called CyberKnife. We actually can lock in on the tumor, and while the patient is breathing and the tumor is moving, the machine, robotically controlled, actually moves in synchrony with the movement of the tumor, so that while the treatment's going on, the machine is always pointing the beam at the tumor, even as it's moving. So that technology, obviously new, and the ability to give a high dose of radiation to a small area, and there's so few side effects that you can give all of the dose in 3 treatments.
Yeah, I mean, again, it's remarkable. And especially, I mean, that's so convenient for people who have to travel, because that's always, the people that we see here in Des Moines are from all over Newton, Pella, Knoxville, Centerville. So anything that's less travel for people, I think is always great.
So the other way, this probably takes 30 minutes to an hour for treatment. The other way, it takes 10 minutes per treatment, but you may go 6 or 7 weeks, 5 days a week. So this is obviously more convenient, more effective, and fewer side effects. So that's stage 1 lung cancer. What does it mean to have stage 2, stage 3, stage 4?
Right. I mean, I think, the whole, just like with other kinds of cancers, as those numbers increase, it just sort of signifies that the cancer has spread sort of further and further. Stage 2 is sort of denotes sort of a bigger size of the tumor and sometimes local lymph nodes that are involved. In 3, you're starting to get into sometimes local, involvement of the chest wall or the more central lymph nodes. Stage 4 is obviously a metastatic type of cancer where it's involving the cancer spread to the liver or the other lung or the other side of the lymph nodes or fluid around the lung or fluid around the heart or the bones or the brain.
So when you get stage 4, medical oncology is the primary treatment. And as we said, that is a treatable cancer, but at stage 4 is not curable. So it's figuring out the best way to try to get the cancer under control. Stage 3 is a really common stage of cancer. Right. And that's where, as you said, primary tumor, but you already got lymph nodes involved in the center part of the chest, but it hasn't gone anywhere else. Right. So it is a potentially curable cancer, but in that situation, the preferred treatment is using a combination of once a day radiation for 6 to 7 weeks, along with chemotherapy at the same time, and adding in immunotherapy as well.
Right. And then sometimes we're doing like neoadjuvant sort of things where giving those kinds of treatments up initially, seeing if you shrink the tumor and seeing if it is then amenable potentially to surgery. Yeah. And there are trials too. I mean, there's a lot of clinical trials that patients who are part of the cancer center have access to.
So stage 2 is a curable, stage 3 is a curable, but stage 1, the chances of cure are way up about 85%. By the time you get to stage 3, your absolute cure rate drops down to maybe 30%. Right. So again, the real emphasis on early detection, find those cancers early.
Exactly.
What are you excited about? Where do you see the future of lung cancer, either prevention, screening, early detection, or treatment? What do you see on the horizon?
I think all of the above. I think, lung cancer, the lung cancer screening nationally and here locally, we screen initially when we started the program, maybe about 200 people a year. Now we're up over 2,000 people a year. But still, that's still probably missing a lot of people that could benefit from screening. So I think an increase in the number of people being able to get screened. When it comes to diagnosis, there are obviously these sort of techniques that we talked about, these new types of biopsy techniques, but then there's blood tests coming up, the liquid biopsy that's always just around the corner, but never not quite there. Mm-hmm. But I think, at our office, we do use a type of blood test sometimes called Notify, is sort of the company name, but it's using certain kinds of tumor markers for a person who has a lung nodule. And it's kind of in the middle of, it could be benign, it could be malignant. We're not sure. Maybe it's not the easiest place to try to biopsy. We can get this blood test and these other sorts of tests that go along with it to kind of help sort of gauge the risk of whether this is more likely benign or more likely malignant. And I think those types of things are probably the next I would think the next big thing is we start to get more and more blood tests to try and diagnose these.
So another one, and we've talked about it on this program before, is the multi-cancer screening blood test, which is already scientifically proven to be helpful, but we haven't shown yet that this particular way of screening for cancer reduces the death. So let's talk about that a little bit. So this is we now have the ability to draw some blood from a person and to find bits of cancer DNA that the cancer cells have shed in the bloodstream. And there are currently about 39 different cancers that can be found by doing this blood test that can determine, is there a cancer in the body?
Right.
We're still trying to figure out, if we do the blood test and it's positive, can then we find the cancer?
Right.
And do we find it at a stage that makes it more curable? So that is a screening test that will be useful, not just for lung cancer, but for, as I said, at least 39 different cancers.
Right. I mean, I think, that's sort of, again, that's the future, and really trying to figure out how best to use that data when it comes back. So that, I mean, that's always the problem with screening, and any type of screening. Is it cost effective? Are we causing more harm than benefit? Are we, that's been the debate about PSAs forever. We're finding people with elevated PSAs. Are we, finding people who have prostate cancer that really need to be treated, and these that would actually cause problems, these sorts of things. So that's probably the next big step in this, is trying to kind of dial in and figure out, what type of patients and what type of blood tests, and how to interpret that in the best, most cost-effective way that's not going to cause people to undue stress, and also to have to go undo biopsies or testing or procedures.
Yeah, and you brought up a really good point, and I think prostate is one of those. Not every cancer needs to be treated.
Right.
We all have cancer cells in our body that usually the immune system takes care of before it becomes clinically significant. But some people have a type of cancer where without treatment, it's just going to stay put for decades and decades, and we can live peacefully with the cancer and not undergo all of the side effects that might happen from an aggressive treatment. So people are aware of that with some prostate cancers. I think people are aware of that with some breast cancers. I think people aren't aware that there are some lung cancers that you can't show the treatment makes the situation better, that some very well-behaved lung cancers don't result in death, and that active surveillance may be the best method, because active surveillance has fewer side effects than a surgery or a radiation.
Right. Yeah, certain kinds of adenocarcinomas.
Yeah, and a lot of people, I think that's kind of not well known.
Right. Yeah, the data's still out for how to approach those the best way.
Fortunately, they often look a little different on the CAT scan, and they look a little different under the biopsy. And we're still trying to figure out, is there some objective way of knowing, if we just watch this patient's lung tumor rather than treating it, will they be okay?
Right. Exactly. And the other thing, when thinking about what we're doing now, that's sort of on the leading edge of things, or these combined types of diagnosing, staging, and treating all in one, all at the same time, in a way. A few weeks ago, or a month or so ago, we did, or my partners, Dr. Alamari, who's a thoracic surgeon, and Dr. Wilcox and Westerly and Villani, my partners who did the robotic bronchoscopy, did a just robotic bronchoscopic procedure, biopsied the tumor, biopsied the lymph nodes. The pathologists were there. We were able to get a fast reading. Ordinarily it takes like about 2 working days to get results back, but they were able to get a reading back quickly, and showed that the lymph nodes looked okay, no cancer there. Showed that the spot, the lesion was a type of cancer. And so all at the same time, while the patient was in the operating room having the procedure done, same anesthesia, Dr. Alamari was able to go in and remove that tumor. And, so basically, rather than waiting weeks and weeks to get this thing taken care of, it was sort of all one type
all done
of
in one
procedure.
setting under one anesthesia.
Right. And that's the first time that's been done here in Des Moines, probably, I believe, in the state of Iowa. It's done sometimes at sort of really leading cancer centers like Sloan Kettering, MD Anderson. But I think like with a lot of things that we do here at the MercyOne Cancer Center, the Deming Cancer Center, people who are here in central Iowa have access to really cutting edge types of therapies. They don't have to travel to Mayo or to New York or Chicago to get these types of treatments done. We have them right here.
Yep. Great. I think we're going to open up to questions. So we've got a live studio audience, and they are really alive. And we also have folks watching us live streaming. And so if those of you watching us live streaming want to just put your questions in the comments, and we'll open it up to questions.
What are the factors that are restricting access to the screening of lung cancer? Not everybody's getting it.
That's a good question, and I think that some of it is lack of awareness potentially on the general public's stand from the general public, but also primary care physicians. We try everything we can to get the word out to primary care physicians to make them aware that this, just like colonoscopy, just like mammography, that lung cancer screening is incredibly important, just as important as those. And, I will say the numbers have, as I said earlier, the numbers have picked up greatly. But, I think as the primary care physicians and other physicians become more aware, they can offer it to their patients, and we can have even more patients that are eligible to get screened.
I would agree. Cancer doctors don't do the screening. Screening is for people who don't have symptoms, and that's really the primary care physicians. Compared to how long we've been doing mammograms, doing the CAT scans for screening lung cancers hasn't been around for as long, and so it hasn't worked into the normal flow. Fortunately, patients who are eligible can refer themselves to the cancer center to be evaluated and connected with getting the lung cancer screening. But it's the ideal situation is that every patient, every person has a primary care doctor that helps to oversee, from the time you're born, what vaccines you get at what age, and then once adulthood, what cancer screenings do you get at what age and how frequently. Nobody can be expected to remember all those things themselves. And in the ideal situation, the primary care physician, with the assistance of a computer and AI that keeps track of all of that stuff, can say, okay, Kevin just walked into the room. Bing, his last screening for his colon cancer was this many years ago. He's due. His last screening for lung cancer was this many years ago. He's due, and it just flags all of that. Yeah. So I think we're getting closer with the use of sophisticated electronic medical records with artificial intelligence that oversees all the data to make sure that no one falls through the cracks. Other questions?
Yes. You mentioned just for smokers there is screening. How about a person that lives in a house with higher radon? Is there screening?
Right. Good question. Now, the insurance and Medicare, United States Preventative Service Task Force, all base the recommendations on that original lung cancer screening trial that, looked at cigarette smokers. So actually even pipe smokers and cigar smokers aren't included either. So radon's not included either. I believe some organizations do recommend lung cancer screening for people who have high exposure to radon. I don't know that insurance covers that for sure. That's something that folks can talk with their primary care doctors about to see if they can get that included. But for the time being, Medicare and the United States Preventative Service Task Force don't include radon as in their inclusion criteria.
Other questions?
Yes, I have a question. I'm going to back up one step further. Let's say I'm a regular individual, and I know that I might have a history in my family of lung cancer. what are the things that I look for myself, even before I come to you to say, I suspect something is wrong? I mean, what's my first step to say internally to say I might want to go to see a doctor to get a diagnosis or biopsy?
Right. That's really hard, because lung cancer, the reason that before there was lung cancer screening, the reason that lung cancers were diagnosed at late stage was because lung cancer is one of those ones that doesn't have a whole lot of symptoms initially when it's an early stage cancer. And family history has been looked at in some studies, like the PLOS study. There have been studies trying to look at using family history for as an inclusion criteria for lung cancer screening. Hasn't really panned out yet. So as to your question, what sort of symptoms would you be concerned about? I mean, I think number one, obviously avoid smoking for number one. That's always the best way to not get lung cancer. But symptoms that people may have are persistent cough, coughing up blood. That's not good. Persistent chest pain, weight loss, night sweats. Those are very, non-specific sort of symptoms. It could be anything, but for somebody that's got a significant family history, that's at least something to be concerned about, at least to have a talk with your primary care provider, physician or nurse practitioner, PA about that.
So once you have symptoms, then, if appropriate, your doctor can get a CAT scan.
Exactly.
That's not a screening CAT scan.
Exactly.
That's a diagnostic CAT scan, because the person has symptoms. We need to find out the cause of the symptoms. Whereas
Correct.
the lung cancer screening is for people who don't have
Right.
symptoms,
Exactly.
but are at high risk.
Exactly.
So,
Hello, Maria.
good evening. Thanks for being here. So I'm just curious if any research has been done on if someone has non-small cell lung cancer and then the different biomarkers that are out there, whether they're EGFR, PDR, RAS, whatever. I mean, has research been done to say if you have biomarker EGFR or something else, they are going to do better than others in that group? I know I'm getting really specific, but I'm curious.
I believe so. I don't know off the top of my head, I'm afraid. I know that there are certain biomarkers with adenocarcinoma that I think if it is it ALK, that if ALK is high, I think that sometimes has a better prognosis. I believe. I could be wrong. I'm sorry.
Yeah, I think both
Um,
ALK and EGFR are more favorable than ones that don't have any markers. And there are so many markers now for lung cancer, and I can't remember if it's 13 or 31 that are now FDA approved for adenocarcinoma of the lung. And I'm not sure how all of those stack up, but I do know that the ALK and the EGFR in particular have more favorable prognosis than the ones that don't have any markers. And some of the more obscure markers, I'm not sure how they fit into the prognosis. So, and then you would have to also, a good question that I don't know the answer of that somebody might, is what's the likelihood that the various markers present as stage 4 versus stage 1, or the other stages? So what's the likelihood that they're more likely confined rather than metastatic? And then based stage for stage, do they end up having more favorable? So I know that the ALK and the EGFR do. I'm not sure about all of the other markers. It's unusual to have multiple markers, but sometimes you do. As well, it's not that unusual if you throw in PDL1, which is not so much as a marker as to determine whether that cancer cell is likely to respond to immunotherapy. And so now we're much more commonly going to be mixing chemotherapy and immunotherapy and targeted therapy. So the term targeted therapy is when you've got a marker like an EGFR and ALK, where they have actually created, designed treatment specifically for those tumor cells. And I just did a time check. We're out of time. So great questions. I'm sorry if we didn't get a chance to answer all your questions. I got to let you guys know that Above and Beyond Cancer is going to Africa for 10 days. So for the next 2 Wednesdays, we won't have a live presentation. So don't come the next 2 Wednesdays. All of our presentations from the last several years are all available at the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. So you can watch some reruns for the next 2 weeks. Our writers aren't on strike,
That's right.
but
Yeah.
we're not going to have a TV show the next 2 weeks. And we'll be back 3 weeks from today. Let's see, today is the 7th, and 7 and 21 is 28. So on the 28th, we'll be back live. So please join us then. Thanks again, Dr. Neil Horning,
Thanks.
for being with
Appreciate
us.
all. It was my pleasure.
Thanks to all of you for being here. Have a great weekend.
Thanks.